All right, let's dive right in. Today, we're going to break down the precise protocol for antibiotic prophylaxis for a really specific and frankly high-stakes procedure, the endoscopic cleavage of a Zenker's diverticulum. We'll get into the evidence and the strategy behind it all. So here's our roadmap. We'll start by defining the surgical challenge itself. Then we'll identify the microbial bad guys we're up against. After that, we'll cover the specific drug regimen, nail down the timing, talk about the core principles behind all of this, and finally, we'll wrap up with a few case studies to see it all in action.
Okay, first things first. Before we can even talk about the solution, we have to have a crystal clear understanding of the problem. So what exactly makes a Zenker's diverticulum such a unique surgical challenge? Well, a Zenker's isn't just some simple anatomical quirk. You have to picture it as this little pouch, this outpouching in the pharynx where everything, food, saliva, you name it, can get trapped and just sit there. It basically creates a contained, stagnant reservoir of bacteria, turning what should be a fairly clean surgical field into a potential time bomb.
And here's the real kicker. The very act of fixing the problem, the surgery itself, where you have to cut through that mucosa, creates a direct, open highway for that bacterial soup to spill into the deep spaces of the neck and chest. This can lead to mediastinitis, which is an absolute catastrophe. It's a devastating and often fatal complication.
So knowing that risk, it becomes incredibly clear why our choice of antibiotics is so important. But to pick the right drug, you first have to know your enemy. We need to profile the specific pathogens we're expecting to find. The oropharynx is, let's be honest, a complex microbial jungle. So our prophylactic coverage has to be broad enough to handle the usual suspects in head and neck infections. We're talking about Staphylococcus aureus, gram-negatives like Enterobacteriaceae, and of course the whole host of anaerobic organisms that are just part of the normal oral flora.
Okay, so we know the battlefield, we know the enemy, and we know the stakes are incredibly high. So what's the play? What is the specific pharmaceutical shield that we bring to this fight?
The standard regimen is a really elegant and effective 1-2 punch. We use Cefazolin, which gives us fantastic coverage against gram-positives, including Staph aureus, and we pair that with Metronidazole, which is an absolute powerhouse against anaerobes. It's this dual approach that gives us that comprehensive protection. And of course, for patients with a significant penicillin allergy, we have a clear backup plan with either clindamycin or vancomycin. Now, having the right antibiotics is really only half the battle, because for them to work, they have to be in the tissue at the exact moment of that first cut. So the timing of administration isn't just important, it is absolutely everything.
This right here, this is the therapeutic window. You have to give the IV antibiotics between 15 and 16 minutes before that first incision. That is paramount. Why? Because this timing ensures the drugs have circulated and reached bactericidal concentrations right there in the target tissue at the very moment of potential contamination. Any earlier, and the drug levels might start to drop off. Any later, and the bacteria have already snuck in the door.
So let's map this out. The whole thing kicks off with that critical pre-op bolus we just talked about. But because the risk of a post-op leak is real, we don't just stop there. We extend that protection for a full 24 hours. Now, you might see a switch from cefazolin to cefuroxime post-op, which is often just a practical decision based on dosing schedules. But the key is that we continue the metronidazole to maintain that full protective shield while the initial healing begins.
Let's just zoom out for a second and look at the guiding philosophy here. Because these principles don't just apply to this one procedure. They're really the foundational rules for all surgical prophylaxis. This is the playbook.
At its heart, this is all a balancing act. We're trying to protect the patient from infection right now, while also preserving our most precious antibiotics for the future. That's why we lean on simple, uniform regimens. It just cuts down on errors. It's why we use drugs that are different from our go-to therapeutic agents to slow down resistance. And it's also why robust infection control programs with active surveillance and reporting are absolutely non-negotiable. It's how we keep these protocols sharp.
I think this quote just perfectly captures the mindset you have to have. With a procedure this risky, you have to assume that microscopic contamination is inevitable the second that mucosa is breached. The alarm has already gone off. So this isn't just about preventing an infection, it's a rapid, powerful defense against a threat that we assume is already present.
Okay, enough with the theory. Let's see how these principles actually play out in a few different clinical scenarios.
So first up, we have a patient getting a laryngectomy, and we know the procedure is going to involve opening the pharynx. Think about that. We are intentionally entering a contaminated space. So what does that tell you about the prophylaxis we need?
Yup, if you said Cefazolin plus Metronidazole, you nailed it. By definition, this is a contaminated head and neck surgery. That introduction of pharyngeal flora into the deep neck tissues, it's like a microbial invitation you have to very, very firmly decline.
All right, case number 2. Let's switch gears completely. Now we have a clean procedure, a pediatric cochlear implant. We're not breaching the pharynx, but we are putting in a foreign body. How does that change the calculation?
For this one, a single preoperative dose of Cefazolin is the standard of care. We don't need the metronidazole because we aren't worried about oral anaerobes. Here, the target is different. We're zeroing in on the skin and middle ear bugs like SRES that pose the biggest threat to that new implant. The goal is to prevent a truly devastating device infection. And for our last case, let's look at something we see all the time. It's a scenario where the gut instinct might be to just give antibiotics, but the evidence actually points us in a very different direction.
And the answer is you do nothing. No general antibiotic prophylaxis is indicated here. And this case is a perfect illustration of targeted prevention and antibiotic stewardship. Without any high-risk factors for endocarditis, the risks of giving unnecessary antibiotics, like side effects and promoting resistance, they just outweigh any potential benefit.
And all of this really leaves us with one final, crucial question for the future. The pathogens we're fighting are not standing still. They are evolving, and antimicrobial resistance is one of the biggest threats we face. So while the protocols we've covered today are solid based on the best data we have now, how do we, as a clinical community, ensure our strategies continue to adapt and evolve to stay effective for the patients of tomorrow?